Hi, my name is Dr. Forrest Cummings, and I'm here to talk about one of the best endocrine diseases, Cushing's disease. Thanks for joining me today. Let me tell you a little bit about myself. As most of us, I always wanted to work with animals. As I was growing up as a little child, about 10 years of age, I knew I wanted to be a veterinarian. Went through the schooling, went to the University of Kentucky for my undergraduate animal science major, biology minor, and from there went to Tuskegee University, College of Veterinary Medicine, and graduated vet school in 2005. After which I did a year internship, a rotating internship at the University of Tennessee, College of Veterinary Medicine. So after starting at the University of Kentucky, I met Dr. Todd Markham, who was my mentor growing up, and introduced me to small animal general practice medicine, and I fell in love with it. After graduation, I went to Tuskegee University, College of Veterinary Medicine, with the intention of going back and doing general practice, and I've learned about the internal medicine specialty. So after graduation from Tuskegee University, I started a year rotating internship at the University of Tennessee in Knoxville. I moved to Florida to work emergency medicine at a specialty hospital. In my time off, I also did relief work for some of the local general practitioners there in the city, and moved back to Louisville, Kentucky to complete my internal medicine residency in 2011. Ever since, I've stayed here in Louisville, Kentucky to be one of the veterinary small animal internal medicine specialists. So I have such an interest in Cushing's disease and all endocrine diseases, but Cushing's disease in particular because it is so common and we see it a lot in the practice on a daily basis. Annually, we could easily see 80 to 100 cases a year. And it is a very interesting disease because of the ways that it can present, and the success rate is high, and you know that you're helping the animal in the process, and the client is happy, and it's just such a rewarding condition to treat because you know you're doing right. So before we get into the talk of Cushing's disease, I just want to give an outline of how the talk would go. So I want to talk a little bit about the pathophysiology, some of the diagnostic testing involved, treatment options, and I want to conclude with some case presentations. So what is Cushing's disease? By the strictest definition, it is excessive steroid circulation within the bloodstream. You have naturally occurring Cushing's disease, which will be endogenous, or steroid production by the body. That can come from the pituitary gland driving that, or it can come from the adrenal glands driving that. You also have exogenous Cushing's disease or iatrogenic Cushing's disease, and that's the result of you or I giving our animals medications, steroid medications, whether that is a topical variant, whether that is oral, whether that is an injectable. All of these things, if given in high enough doses, can result in Cushing's symptoms. So the hypothalamus in the brain is going to be responsible for releasing corticotropin-releasing hormone, which is going to act on the anterior pituitary, and that's going to release adrenocorticotropic hormone. The adrenocorticotropic hormone then acts on the adrenal gland itself to release these steroids, cortisol. When cortisol levels are sufficient in the bloodstream, they will negatively inhibit more release of corticotropin-releasing hormone from the hypothalamus, as well as ACTH from the anterior pituitary gland, cutting off stimulation so that the body naturally regulates its own cortisol concentration. So the adrenal glands are located within the abdominal cavity, just cranial to the poles of the left and right kidneys. The adrenal cortex is composed of three different layers: the glomerulosa, the fasciculata, and the reticularis. The glomerulosa layer is going to produce your salt or your mineralocorticoids. The fasciculata layer is going to produce your sugar or your glucocorticoids, and the reticularis is going to produce your sex hormones, your androgens, estradiol, testosterone. So all steroid production by the body ultimately comes from cholesterol, and through a series of enzymatic pathways, that cholesterol is converted into the salt, the sex, and the sugar hormones. So the effects of your mineralocorticoids are to regulate your electrolytes, namely your sodium and your potassium. It does that through excreting excess through the kidneys and also through your sebaceous glands. The androgens, the estrogen or the testosterone, depending on male or female, obviously will give you your more feminine or more masculine physical features. The effects of the glucocorticoids are numerous. They help control your carbohydrate metabolism, your fat metabolism, protein metabolism. They also have anti-inflammatory effects, and they have anti-insulin effects. Some of the clinical signs that are commonly seen with Cushing's disease can include increased thirst and urination, or polyuria, polydipsia, polyphagia, increased appetite, weight gain, panting, generalized muscle atrophy, a large pendulous abdomen, symmetric truncal alopecia, several dermatopathies from hyperpigmented skin to comedones to non-healing wounds and crust, and then lastly, sudden acquired retinal degeneration or acute blindness. So remember, when this dog comes to your clinic and the owner says, "Hey doctor, I have these symptoms going on with my patient," the first thing you're going to do is to get what we call a general health profile or a minimum database. And that's generally going to include your complete blood count or your CBC, your chemistry panel, your urinalysis. Depending on the symptoms that they show, you may also recommend internal imaging in the form of radiographs, ultrasound of the abdomen, of the thorax, and then ultimately the endocrine testing. In rare situations, you may also recommend advanced imaging in the form of a CT or computed tomography or an MRI, magnetic resonance imaging. Some of the common CBC abnormalities that you can find would include the classic stress leukogram, classified as the mature neutrophilia, a monocytosis, and an eosinopenia. You can also see a thrombocytosis, the cause of which is not really understood, but can be seen in the majority of dogs with Cushing's disease. In your biochemistry panel, things that you would see are the classic cholestatic liver enzyme pattern. That is where your alkaline phosphatase is generally much greater than your ALT elevation. You can also see elevated lipid levels. Remember, this is all stemming from cholesterol. So when the body is demanding more cholesterol, you'll have higher levels in the blood. You can also see a hyperglycemia, relatively mild, but present. You can see decreased creatinine due to the decreased muscle mass that the patient is experiencing. You can also see electrolyte abnormalities due to the excessive urination and loss of electrolytes through the kidneys. Some of the urinalysis abnormalities that you can see is a dilute urine. It can be less than generally about 10-20 because the owner is allowing them to have more water because they have excessive urination. So the concentration can be lower, as opposed to if they're in the hospital, they may not be have access to as much water as they normally would at home, so the concentration can go up. This is a good indicator to let you know that the cause of the elevated water intake and urination output is not due to primary kidney disease because you can still concentrate the urine. Other things that you may see is protein loss in the urine. This can be the result of hypertension as a result of your Cushing's disease, or it could be the result of glomerular destruction or glomerulonephritis. You can also see bacterial infections or bacterial cystitis in approximately 50% of dogs with Cushing's disease. And some can even have urolithiasis or bladder stones. So moving into the imaging portion of this dog that came into you for signs of Cushing's disease, most would start with an abdominal radiograph. Things that you could see would be hepatomegaly or an enlarged liver. You can also see those mineralized foci or the uroliths in the bladder. Remember, if they came in for panting and abnormal breathing, you would want to start with thoracic radiographs to rule out other causes for the panting, such as lymph node enlargement, masses within the chest cavity, bronchitis, etc. After the radiographic study has been completed, the next diagnostic would be to do the abdominal ultrasound. You want to get a look at the big liver that you saw on the radiograph to ensure that there is no overt tumor. You want to measure those adrenal glands and make sure that you either have a pituitary-dependent Cushing's disease with bilateral adrenal gland enlargement, or is this one very large adrenal gland where you're more suspicious of an adrenal gland tumor. Remember, the clinical signs that we talked about with Cushing's disease also has a lot of overlap with two very common endocrine diseases, namely diabetes mellitus and hypothyroidism. Diabetes can also experience signs of increases in thirst, urination, increased appetite, and from the owner's perspective, they can't differentiate either one. Just remember that should be on your radar when screening these dogs for Cushing's disease. The same for hypothyroid. You can see elevated liver enzymes. You can see elevated cholesterol levels. You can see the pendulous abdomen. You can see the dermatologic changes. So just please note that these other conditions may be present and it may be indicated to check for these conditions. Notably, you should check for glucose in your urine if you're diabetic. Cushingoid dogs do not have glucose in their urine. If you're suspicious of diabetes, think about performing things like a fructosamine level, which will give you about a 2 to 3 week period of how well this dog has been regulating its glucose. About 5% of dogs with Cushing's disease can also have diabetes mellitus. Also remember, the hypothyroidism is very commonly seen in dogs that can have Cushing's disease. You can see it in approximately 25% of dogs with Cushing's disease. However, don't be fooled because you do have a sick animal, and with that, you can get sick euthyroid in about 50% of dogs with Cushing's disease. So just be careful about overdiagnosing hypothyroidism in the beginning stages of diagnosing Cushing's disease before it is controlled. So now that you've established that you probably have Cushing's disease, the next step is to make the diagnosis. And so you have basically two different ways to do that. You have screening tests and you have differentiating tests. You have three primary screening tests. You have a urine creatinine to cortisol ratio, you have an ACTH stimulation test, and you have the low-dose dexamethasone suppression test. With the differentiating test, you have the high-dose dexamethasone suppression test, an endogenous ACTH, and the abdominal ultrasound. So the urine cortisol to creatinine ratio, it's a really easy test to run. It's extremely sensitive at 100%. So when you have cortisol being excreted in your urine, it's a positive for Cushing's disease. However, it's a positive for anything. Remember, cortisol is a stress hormone, so even a simple trip to the veterinary clinic can make a UCC ratio positive. And that goes into the next thing. It lacks specificity because of that. So always be cautious when performing a UCCR because it can give false positives. This usually requires further testing. The other screening test is an ACTH stimulation test. This test actually measures your adrenal gland reserve. And so what you would do is to take two different samples, 1 hour apart, and you would give a synthetic hormone to help release the reserve from your adrenal glands. The medication that we use is called cortisol, and what it does is to stimulate that cortisol. You measure the 1 hour post sample, and as long as it falls within or without the reference interval, you can make a diagnosis. The biggest disadvantage of this test is the sensitivity, or the ones that you'll get the true positives on. It can range as low as 60%, but as high as 85%. It's very specific though. So the specificity for this test generally runs between about 85 to 90%. You want that normal dog, the non-Cushingnoid dog, to float somewhere between about 5 micrograms per deciliter to about 17 micrograms per deciliter. Once you get above that range, now you're raising the concern that I may have a dog who's Cushingnoid, and you need to start the therapy at that point. The advantages of the ACTH stimulation test are that this is the only test that will monitor drug therapy once you start treatment. This is very rapid. It's a 1 hour test, and you usually get those results within 1 to 2 business days. Now they have machines that can actually perform this test in-house, called the TrueForma machine. So you can find out real-time results and get your answers immediately. And this is the only test that's going to differentiate an iatrogenic Cushing's dog from a naturally occurring Cushing's dog. The biggest disadvantages of this test can be the cost. Cortisol can vary depending on its availability, and cost may rise depending on the size of the dog. The cost may rise with the test. And the other disadvantage is that it has a low sensitivity. All in all, the ACTH stimulation test is a great test to run. You just have to determine if it'll be the best test to run given the situation. The next screening test is the low-dose dexamethasone suppression test. This is an 8-hour test where you take 3 different samples. You'll take a baseline, and you'll take one test at 4 hours and another blood draw at 8 hours. You can do this test with dexamethasone or dexamethasone sodium phosphate, also known as DexSP. It has a really high sensitivity of 85 to 95%, but a moderate specificity at 70 to 75%. The results are relatively quickly, again, about 1, maybe 2 business days. And the way that you interpret this test, your 3 different samples, would be to measure whatever your baseline is, and at the 4-hour mark, you're looking for suppression. If you can get suppression to less than 50% of your baseline or less than 1.4 micrograms per deciliter, you have some valuable information. You have to compare that, though, to the 8-hour value. What you're looking for in a normal, non-Cushingnoid dog would be it stays suppressed at the 8-hour mark, meaning it is still less than 50% of your baseline or less than 1.4. If you have escape of your suppression at the 4-hour mark or the 8-hour mark, you have a dog who has Cushing's disease. Another test that you may run is an ACTH stimulation test, but it's actually going to assess all of the adrenal hormones that we had mentioned previously. This test is run in specific situations where you run a test to look for a cortisol excess, either via the ACTH stimulation or the low-dose dexamethasone suppression test, and it comes back normal or unremarkable. However, you have a dog who still may be Cushingnoid. And so then you would perform the adrenal hormone panel that is done through the University of Tennessee's College of Veterinary Medicine. The biggest disadvantages of this test would include the cost, and it includes a longer turnaround time, generally between about 7 to 10 business days. So when you're trying to diagnose Cushing's disease with the adrenal sex panel, also called atypical Cushing's disease, we generally do not lead with this test, primarily because of the expense, but also because the most common elevation is going to be cortisol. The previous test that we mentioned will measure cortisol exclusively. So the adrenal sex panel is a test that you would use on a case-by-case basis, depending on the results of your previous screening test and depending on the symptoms that the animal is experiencing. Moving into the differentiating test, we have the high-dose dexamethasone suppression test. It's ran just like the low-dose dexamethasone suppression test in that it's an 8-hour test, 3 different samples, and the biggest difference is that the dose of the dexamethasone or dexamethasone SP that you're using has increased tenfold. So instead of giving 0.01 mg per kg IV of your steroid for the low-dose dexamethasone suppression test, the high dose is ran at 0.1 mg per kg of steroid IV. And the way to interpret this test is going to be measure your baseline. At the 4-hour mark, are we getting suppression? Yes or no? It still has to meet the greater than 50% of baseline or less than 1.4. At the 8-hour sample, if this test is still suppressed 50% of baseline or less than 1.4, it will help you differentiate between the pituitary micro or macroadenoma or pituitary-dependent Cushing's disease versus an adrenal tumor if you do not get any suppression, i.e., you do not meet your 4-hour or your 8-hour requirements. So if you do your high-dose dexamethasone suppression test and you see that you have a dog who has no suppression, so you're saying, okay, I have a Cushingoid animal, now you're trying to determine if this is an adrenal tumor, which it may be, or it still could be pituitary dependent. In those situations where you're trying to further differentiate adrenal tumor versus pituitary dependent, you can perform the endogenous ACTH. So with that test, you have to call your reference lab that you generally use, and they will send you special tubes that have to be temperature controlled. They're ship chilled. You have to get that back to them generally the same day, chilled. So it sets up for a lot of room of error if you don't follow the very strict guidelines that come with this test. However, it does differentiate very well between an adrenal tumor versus a pituitary dependent tumor. Adrenal tumors generally result in low levels of endogenous ACTH. Pituitary dependent Cushing's disease, they will have normal to elevated levels of endogenous ACTH. The prognosis with Cushing's disease ultimately depends on which form you have. If you have an adrenal dependent form, the benign version, the adenoma, generally comes with an excellent prognosis with surgical removal. In contrast to the adrenal carcinoma, they have a very poor prognosis. They have to be taken out surgically. However, they are very aggressive locally. Oftentimes you can see that it has infiltrated into the vena cava if it's a right adrenal gland tumor. They have a very high metastatic rate into the liver, making surgical intervention not an option in many dogs. And they overall have a pretty poor long-term prognosis after removal because they are very highly metastatic. So if you see an adrenal tumor, always before any sort of surgical intervention, you should take thoracic radiographs, if you have not already done that, to look for evidence of distant metastatic disease, and ideally abdominal CT or CAT scan to look for evidence of cable thrombosis, to look for evidence of metastatic disease into the liver, things that may not be easy to always find with an abdominal ultrasound. With pituitary dependent forms, these are the cases, fortunately, that we generally tend to see on a daily basis. They come with a really good prognosis of greater than 3 years for dogs who are well controlled. You treat them medically, and the medication they receive is generally given 1 to 2 times per day, and you try to treat them to control their cortisol levels and essentially minimize or resolve the clinical signs that got them into the hospital to see you in the first place. Other potential treatment options can include pituitary gland removal or hypophysectomy and irradiation of the pituitary gland. Neither one of these procedures are done commonly here in America, but the irradiation therapy, generally that pituitary tumor will come back. Hypophysectomy, again, not commonly done. We generally don't do a lot of brain surgeries here in America. And then the biggest thing with treatment is going to be your medical management. 3 medications that you can use to treat your Cushing's disease primarily, and that's going to be ketoconazole, mitotane, and the gold standard trilostane. So ketoconazole is not your first option when treating Cushing's disease because it's not that effective at really controlling your steroid production, but it is an option, and I do like to use this option in cases where the families have financial restrictions and cannot afford the gold standard, which is going to be your trilostane or Veterinary therapy. But the way this medication works is by inhibiting your cytochrome P450, which is pretty high up in the chain when you're trying to form steroids to begin with. It disrupts your imidazole ring, and it ultimately gives you a faulty molecule that's the basis of your steroid synthesis. So if you can disrupt the foundation, then you should get control of your Cushing's disease. Why that doesn't relate to clinical improvement in all cases, we don't really know. But again, this is something that I would definitely recommend at least to be attempted if it comes down to I can't treat with the gold standard and they have a poor quality of life because the symptoms of Cushing's disease are too much. It does require daily administration, and it does require that you monitor the liver values routinely because your azole medications like ketoconazole, fluconazole, they can cause hepatopathy. So keeping a close eye on your liver panel, your liver enzymes is important if you start this medication. Another medication that you can use is called mitotane or Lysotrin. Here recently, this medication has been hard to come by because of its availability. In human medicine, this medication is falling out of favor, so the availability on the vet side has decreased as a result of that. The way this drug works is by actually destroying the adrenal gland itself. It causes adrenal gland necrosis. The whole goal is you want to give this medication to slowly destroy the adrenal cortex where the hormones are made. And as they slowly start to regenerate, here comes the next dose of medication to destroy that cortex once more. As you can see, there's a fine balancing act between too much medication and causing too much adrenal necrosis and getting yourself into a crisis, also called iatrogenic disease, where you have too few steroids, and maintaining an acceptable, quality, healthy animal. So that medication, again, used to be the gold standard, but it is now shifted to the medication that is commonly used called trilostane, or brand name Veterinary. Veterinary is an enzyme inhibitor of your 3-beta hydroxysterone. This medication, referring to our chart previously, will inhibit the steroid synthesis. And so if we can inhibit steroid synthesis by blocking enzyme production, we don't have adrenal necrosis, which was the biggest disadvantage of the mitotane, and we don't have to worry about as much iatrogenic Addison's disease. There are scattered reports of Veterinary or trilostane causing adrenal gland necrosis. However, it's rare, it's not that common, but again, please be mindful and on the lookout for it, because we will be monitoring the steroid levels, the cortisol levels, with the ACTH stimulation test once we start therapy, and we adjust these medications as needed. So it's very important that we pay close attention to monitoring for symptoms of Addison's disease or too few steroids, which can manifest as a decrease in activity, a decrease in appetite, vomiting, lethargy, diarrhea. Always tell the owners, if you see any of these medications, regardless of the treatment option being used, to stop the medication and to call your clinic immediately for further support. And speaking on the trilostane a little bit more, I alluded to the financial component to this medication. So it can be cost prohibitive for larger animals. It's generally dosed at around starting dose 1 to 2 milligrams per kilogram, 1 to 2 times per day every 12 to 24 hours. And as mentioned before, the smaller the animal, the cheaper the medication can be. However, if you have a 60 or 70 pound dog, this could run into the hundreds of dollars per month for a treatment of Cushing's disease. Regardless, the follow-up for this medication, once they start it, is the same. Once you start therapy, you need to perform an ACTH stimulation test, not a dexamethasone suppression test, within 2 to 3 weeks after starting therapy. And what you're monitoring is that cortisol level. Ideally, you want that pre and post sample to stay below 10 micrograms per deciliter for your pre and your post samples in order to maintain good control. Generally speaking, if it's below 10, you will see less increased thirst, urination, the appetite generally returns to being normal, you start to see hair growth return, you start to see amelioration of all of those clinical signs that they were experiencing beforehand start to resolve. Generally speaking, the first symptoms that you see improve are going to be the thirst, the urination, and the appetite. Things like the hair growth can take a couple of months to really start to pick up, but you should start to see the effects of treatment relatively quickly. Most dogs can become controlled within 2, maybe 3 months. You can find your maintenance dose. So after your initial ACTH stimulation test, you may or may not adjust the dose, but if you make an adjustment based on the latest ACTH stimulation test results, you must then again perform another ACTH stimulation test 2 to 3 weeks after any dose adjustment. Once you have your maintenance dose interval established, check the ACTH stimulation test generally 3 times per year, as a routine maintenance to make sure the cortisol levels are in an appropriate range. If you find that you have oversupplemented with medication and you are now iatrogenic Addisonian, then you have options to give that animal either mineralocorticoid supplement, and that's going to be your Zycortal or Percortin, if available. Zycortal is generally what is out there right now, as well as glucocorticoid supplementation in the form of prednisone. The prednisone must be given on a daily basis. The injectable mineralocorticoids, those are generally given every 4 to 6 weeks primarily, subcutaneously or intramuscularly, generally given at the veterinary hospital because it must be dosed on weight. So now the question is, will my dog have to be maintained on the supplemental steroids because the steroids were deficient? The question of will it rebound, will it recover, is unknown in the beginning stages. So it's going to take some close monitoring. So the best way to do it is to start your mineralocorticoid, to start your glucocorticoid, and you would start them at their physiologic doses. If they start to become Cushingnoid or show signs of Cushing's disease when they are on these medications, it is possible that they have rebounded from the insult that their adrenal glands have had. And now you may be able to wean them off of the supplemental steroids that you had. This, you would have to make that decision in the moment based on the case. And don't forget to monitor the clinical signs to help determine when and if the supplemental steroids can be discontinued with your Zycortal and prednisone therapy. So in summary, please know what I wanted you to get out of this talk is that Cushing's disease is a very manageable disease to have. Males are less commonly affected than females. It's usually a small to medium-sized breed dog that tend to get it. Multiple tests are required to make the definitive diagnosis. And then always remember that pituitary-dependent forms is much more common than the adrenal-dependent form. Your drug of choice is going to be trilostane or Veterinary, and always, always, always please monitor for signs of Addison's disease as a result of potential oversupplementation. But Cushing's disease is a very manageable disease. That's what I really like for you to get out of this talk. Comes with a good prognosis, long-term prognosis, and the animal can have an excellent quality of life when adequately controlled. If you have any questions or would like to reach out, you can find me on LinkedIn. Thank you so much for watching.